Hello everyone, and welcome to the Minnesota STEM Book Festival Health Sciences panel, Preparing for the Next Pandemic. My name is Chris Dahl, and I'm a reporter with SIGGRAPH News at the Center at University of Minnesota's Center for Infectious Disease Research and Policy. Our conversation today will feature Dr. Michael Osterholm, internationally recognized epidemiologist, University of Minnesota Regents Professor, McKnight Presidential Endowed Chair of Public Health, and Director of the Center for Infectious Disease Research and Policy. Dr. Osterholm is also the author of a new book on pandemics and preparedness called The Big One: How We Must Prepare for Future Deadly Pandemics. I'm going to be speaking with him about the book and the realities and the challenges of responding to infectious disease pandemics in the 21st century. Joining us for this conversation are Dr. Christine Kletti, who graduated from the University of Minnesota Medical School and has worked in emergency medicine for over 20 years. She is currently enjoying a transition to retirement, working in the Emergency Physicians Professional Association urgency rooms. And Dr. Katie Schaefer, a board-certified pediatrician, currently practicing at Southlake Pediatrics. Her areas of interest include newborn and adolescent care, asthma care, and partnering with families to promote healthy lifestyles. So I'm going to begin with some questions for Dr. Osterholm, and then Dr. Kletti and Dr. Schaefer will join the conversation to discuss how practice and policy intersected during the COVID-19 pandemic, and why pandemic preparedness must remain a priority for communities and leaders alike. So Mike, for those in the audience who haven't read The Big One, can you start by giving us a brief synopsis of the book and what you and your co-author Mark Olshaker were trying to achieve? And I think it would be interesting for the audience to hear how this project came to fruition.
Well, thanks, Chris. First of all, let me just say that it's a real honor to be here, and thank you for you being here and for Chris. And also, just put a plug in for STEM right now. Science is under such attack, and if it was ever a time that we needed to reinforce the importance of STEM, it's right now. And I have such admiration and respect for our teachers in particular, who are out there on the front lines having to deal with issues when we talk about climate change, about the physical, about the politics, all these things. So I just can't say it in strong enough terms. The second thing I have to say, isn't it beautiful to be here? I actually went back and with some help from a couple of colleagues figured out I actually gave my first talk at this building in 1978. Nice. And so I've been around for a while, I'm an old man. And it's beautiful to be here. Well, first of all, let me kind of go at the elephant in the room here. We can't talk about with any certainty what we need to do to plan for the next pandemic if we can't even figure out what the hell we're going to do the next 24 hours. And right now, we are in such a crisis mode in this country where we have an administration that's attempting to eliminate vaccines, has vaccines across the board. We see this issue around, you saw it over the weekend, 1,300 people were fired at CDC, and now some are getting hired back. But the bottom line is it's just a shell of what it once was. The advisory for immunization practices, which we all have used as the guidelines for how to give vaccines and who should get vaccines, were all fired and replaced with anti-vaccine advocates. And so I just want to say that up front now, that we will talk about the pandemic, we'll talk about what it means to be prepared for a pandemic. But in the first instance, we have some much bigger fish to fry. And our center actually has taken that issue on. We've started what's called the Vaccine Integrity Project, which involves experts from around the country. And we're trying to take head on the mis and disinformation coming out from this administration and what's happening here. So it's going to be a hell of a challenge for the next 3.5 years. But let's take the step back and say about pandemics. You know, I first got interested in this issue of massive attacks on society, you might say, by a microbe, way back in the pre-2000 time period, before 9/11 happened. And ironically, I wrote a book and it was published in 2000, and 9/11 of 2000, and it was entitled Living Terrors, What Our Country Needs to Know to Survive the Coming Bioterrorist Catastrophe. And then, of course, we had the hit with anthrax following 9/11. And then, in addition, in 2017, I published another book called Deadly Ascending: Against Killer Germs. And that one was about what was confronting us. And I had 3 chapters in there on what a pandemic might look like. And unfortunately, it unfolded pretty much within that book, except we thought it might be an influenza virus. It turned out to be a coronavirus. The bottom line message is pandemics are historic in nature. They've occurred dating back to the Greeks and the writings of the Greeks talking about what happened and spread through the world. We're going to see more. This is when a new infectious agent in terms of, it may not be a new virus as such like influenza or coronavirus, but it's different now. We don't have any human immunity to it, and it's highly infectious. And this, in fact, is what's going to happen in the future. We're going to see more of these. We're going to see more frequently than we have in the past. In 1918, influenza was considered the big one until, of course, we got to COVID. And COVID, while not even as big as 1918, was still big. Well, think of the following scenario. This coronavirus basically is part of a family of coronaviruses that have caused us challenges in the past. In 2003, we had an outbreak called SARS, severe acute respiratory syndrome, came out of China. And in that situation, it was a virus that wasn't all that infectious in the people who got infected, except for some super spreaders that actually did cause big challenges. But we were able to put that one in the box because they weren't that infectious. And I worked a lot on that one because I was at that time splitting my time between the Department of Health and Human Services and our Center University. We thought, well, that's good. More and more like this, we can control. Well, then MERS, Middle East Respiratory Syndrome virus occurred, and it occurred in 2012 from camels to humans on the Arabian Peninsula, unlike the previous ones, which were certain animal species sold in the markets of Asia. And this one had many of the same properties for transmission as we saw with SARS. It wasn't all that infectious except if you had a couple of super spreaders. And I actually worked on the outbreak that occurred in Seoul, Korea, when in 2015 an individual came back from the Middle East and picked it up there, was hospitalized in Seoul in what would be considered their Mayo Clinic of hospitals and clinics. And we watched 87 hospital employees literally become infected, of which a number died. And it was one of those ones that you'll never forget. One of the individuals, the healthcare provider's only exposure was walking through a hallway where one of the patients had sat for the previous 2 hours. Literally, no more than 1 minute through that hallway. Well, again, this one, like SARS, was not that infectious, but for both of them, SARS killed about 15% of the people that got it. Actual MERS killed up to 35% of the people that got it. And so what we're talking about today is the return of that virus with the infectiousness of what we saw with COVID, SARS-CoV-2, which was highly infectious, but it didn't kill like SARS or MERS. Now, we actually have identified viruses in nature, in bats, in China, that have the ability to be transmitted like COVID and have the machinery on board to kill like MERS and SARS. So when we talk about a big one coming down the pike, this is not, some kind of horror movie. This is not somebody just trying to make up something to scare the hell out of you. We do have this potential. We're going to see the same thing with influenza. We're seeing new influenza viruses emerge all the time. We could have a 1918-like one, and we'll talk more about our preparedness here, but I just want to lay the groundwork and say why this is important. It's not if it will happen, it will happen. And I keep telling people, the pandemic clock is ticking again. We just don't know what time it is.
So, a big part of this book, you have this one part of the book is the scenario of this virus that you just described, and the future pandemic it causes. But another big part of this book is an assessment of how the COVID-19 pandemic was handled, what went wrong, and what we can learn from it. And you break those mistakes and lessons down into a few buckets. And I'm just wondering if you could talk about some of those mistakes, maybe highlight a few that you really feel shaped the COVID-19 response.
Well, first of all, let me say that one of the lessons that should have been learned in COVID is you need a hell of a lot of humility to be in this business. And it's really important to share what you know and what you don't know. And when you say you know it, why do you know it? How do you know it? You just can't be a dictum that I said I know it. And if you don't know, what do you do to find out? Our center was on the cutting edge of COVID right from the very beginning. We published our first article, which Chris was party to all of this, in the end of 2019, into 2020, in those first days. And early on, when we looked like it was going to be coronavirus, I actually, in the first week of January 2020, was quite pleased to say, wow, this is not good, but boy, this is a heck of a lot better than the flu. If this were flu, we wouldn't contain it, okay? And we had enough information coming out of Wuhan with all of our contacts that we have. We knew kind of what was going on. Well, then when we found out, wait a minute, this is a coronavirus and it's highly infectious as flu. And that changed it. And actually, our center published a statement on January 20th of 2020 saying, this is the next pandemic, get on with it, we got to be prepared for it. It took WHO 2 more months to come to that point. And we missed that situation. Having been involved, and then ultimately, that first year with the Trump administration, we worked closely trying to help move things along. And then I was asked to join the Biden-Harris transition team after Biden won the election and worked all with that group. So I was really at the front table, you might say, on all these issues. And one of the things that I thought was really a challenge was watching dogma kind of take over. For example, I published a piece in the Washington Post in early March of 2020 saying, do not do lockdowns. Do not do them. They will not work. And all you're going to do is piss people off, okay? And the reason for that was because we envisioned that this was going to last likely multiple years. Could you really lock down for all that time period? Well, the answer was no. You know, you're going to have to. So what are the options? Well, first of all, 41 states did ultimately issue lockdown orders of some kind. Our governor here declared, in fact, non-essential workers to stay home. This was in the end of March of 2020. All the lockdown orders, except for one state, were ended by June because people realized they couldn't do that. Even in our own state, a lockdown was really not a lockdown. It turned out the governor exempted essential workers from the lockdown, and that was 82% of our workforce. So that really kind of, didn't make a lot of sense. But what we had proposed at the time, and subsequently, was the concept of snow days, something we understand in Minnesota. What was the single most important thing in those first months of the pandemic that could save lives was having a healthcare system that was not collapsing. And that was what we were challenged with, so unfortunately. And so what we proposed is, what if every hospital in the country would post their bed census every morning, and if we got to a certain level, we would ask the public, within everything they do, please, now's the time for you to self-protect yourself. Avoid public spaces. Now's the time maybe to shut schools down for a couple of weeks, okay? Get that number back down so that basically it was going to go back up again, and it did that. And so I think people thought, well, we can't do that. And we don't know why, but that's a lesson we should have learned. That would have been an approach we could have taken. I think the other issue that had came up often in terms of our discussions was on respiratory protection. And there's still a divide in the science community, which is to me akin to miasma theories, this idea that air smells so it's infectious, was the fact that we needed with airborne transmission, and this was clearly an airborne transmitted virus. Right now, these people are probably close, because I'm speaking this way, but in 6 to 8 feet, as I talk, my droplets are coming out. They're falling all over the floor here. And there are some infectious diseases. That's how they're primarily transmitted. I know, I get it, all right? But my aerosol is filling this whole room. You in the back are getting hit virtually almost as much as I am. It's like if I was smoking a cigarette up here right now, you would all smell it. That's an airborne transmitted virus. And that's, in fact, what the challenge was, and we did so much to minimize the understanding of that. We spent millions and millions of dollars on plexiglass shields. It made no difference whatsoever. I was actually ordered on multiple occasions when I would attend a Minnesota hospital to go there. I had my fitted N95 on, and I was told I had to take it off and put on a surgical mask because that was the standard in the hospital. It was dead wrong, just dead wrong, okay? And so I think that there are a lot of lessons like that we could have and should have learned. And what I try to do in the book is rather than point fingers, just say, these are the, and I just finally, I had a really good fortune of, after 9/11, I split my time between the university and serving as a special advisor to the Secretary of Health and Service, Tommy Thompson, on bioterrorism issues. And so I did that for 3 years, and that's how I got into all the stars, in fact. But what was really impressive to me is I was there for the early days of the 9/11 Commission. The 9/11 Commission was led by a Republican and a Democrat. It was totally nonpartisan. No finger pointing. They dug up a lot of mistakes that had happened that made 9/11 what it could be. And the report came out, not one word of partisan issues. These are the things we should have and could have learned and we need to do for the future. And some of us have been begging for that same kind of report for hope, saying, think of how we could better prepare ourselves for the future. And so this book, and unfortunately, is kind of a substitute for that because we could see it was never going to happen. And so what I try to do in this book is with the scenarios, and I do paint the scenario that emerges in the book as what would a pandemic look like. And I might add, remember I talked about 25–35% case fatality with MERS? I only said 7.5% in my little scenario, but it was still 7 times higher than we saw with COVID. And so I think that what we're trying to accomplish here is for people with this a scenario that unfolds each chapter, and then the chapter is tied to the events of that part of the scenario, so that people can realize what are the kinds of issues that we really have confronting us. What happened? What did that mean? And so, you know, in that sense, it's a hybrid fiction, nonfiction piece that hopefully enhances the nonfiction understanding.
So I'd like to turn now to Dr. Klenny and Dr. Schaefer, and I'd like to hear about your experiences on the front lines during the COVID pandemic. So Dr. Klenny, let's start with you, and then you can pass the mic to Kate.
So I think we first started hearing about this novel virus that may be coming, and having been around when there was SARS and the Middle Eastern virus, we would infectious committees would come out. They talk with you about donning and doffing, which is how you prepare for a potential infectious agent and how you're going to manage this person. They talk with us about, remind us about our negative flow rooms where we can see these patients, which there are 2 in the emergency department. And so at first you're thinking, okay, this is probably, again, going to be something we think about. We start reminding ourselves about how we're careful, et cetera. And then it became clear that it was going to be something more. I call myself a PGY 29 at this point, which in medical training, postgraduate years, what that stands for. So your first year residency, you're PGY 1. And I think in practicing medicine, you are just continually learning and growing and trying to understand things better, trying to communicate your knowledge better. But this was the biggest, I think, change, flow of information, trying to learn on the run and learn fast that I had experienced in my, at that point, 24 years of practicing. We were getting, so you start off with the initial thing, trying to prep the emergency department. The hospital's telling you how you need to have things set up, what masks you need to wear, where you need to wear them, and those sorts of things. But from the standpoint of being a physician who's going to have a patient come in and I needed to be able to take care of that person, what we really wanted to understand is how are they presenting, what are we going to need to do, how can we manage, how can we help them? And there wasn't a lot of information. Is this going to act like other viruses? Is it going to act different? And it became pretty clear pretty quickly hearing from, and we weren't hearing from China, we were getting our information initially from Italy, where our first connections as emergency physicians, and I think where the first big outbreaks were happening, hearing about how these patients were presenting, which was very different than other things that we see coming in. So they were presenting extremely hypoxic, which means their oxygen saturations were very low. And in general, when you see a patient present with a very low oxygen saturation, we're talking, I mean, extremely low. So 85 to 90% is generally your cutoff of the curve of your oxygen saturation of your hemoglobin start to drop off really quickly. So patients don't tolerate that well. When they're getting to that point, you know you need to intervene. We're talking patients showing up with oxygen saturations in the 70%, so extremely low, which meant we need to take over and help them breathe. And so the initial guidance we were getting was, be prepared to intubate early, and how do you protect yourself and your team while you're doing this? And so lots of conversations on this. And then quite quickly also learned that actually these patients are staying sick for a long time and staying on ventilators for a long time. And we don't have enough ventilators, we don't have enough ICU nurses to to manage this number of patients. And so more guidance about using what we call non-invasive ventilation, other types of ventilating standards that can help care for the patient, but push off needing that vent, which someone else needs right now. So there's a lot of information we were getting and trying to use reliable sources that I used in the past to help me learn. I was looking back at some of the information in preparation for this on, I think it was March 16th, one of the continuing medical education podcasts that I use interviewed a doctor from Italy who was giving us advice on how he was managing patients. And so I think for me it was really interesting, and the first time that I had this really sort of ground up response and learning on how to be prepared. It wasn't things we didn't know how to do, but it was a presentation that was very different, and that makes everyone anxious and trying to learn. So it was just a fire hose of information. My husband reminded me that we were getting phone calls frequently from the healthcare system. We were getting daily emails from our department, and then we were getting these updates frequently from these people that we considered reliable on what was new, how things could be managed, and what you should be thinking next.
So I'm a pediatrician in private practice, so the patients I was seeing were different than what you were seeing. We were seeing the incredibly ill ones, and we were getting kind of the front lines with kids, which fortunately wasn't as bad as getting 80-year-old patients in the ER. But it was incredibly overwhelming. We had a committee that we set up that met daily because things were changing so fast. So we were literally changing our practice and how we approach patients every day. We have 4 different offices, and that included where do we send patients? Do we send them to one office if they're sick and another and they're well? How do we divide that up and try to keep people healthy? And it was extremely difficult the more it grew, because you were seeing so many kids that needed to be seen, and then we started getting sick. And so you start to lose your medical assistants, you start to lose your physicians and all of the people that are trying to care. And this isn't, hey, go out while you're feeling sick. It's, okay, now you're out for the next 10 days. You can't come back no matter how you feel. And so it was a fire hose. It was a fire hose of patients and trying to plug holes. And I don't think I've ever worked more than I did those first couple of years, because people would get sick and you just, if you weren't working, you came in. So it was very hard to meet the demands of what everybody needed. And you had to just really stay on your toes. Whatever you thought one day, you couldn't be too wed to, because it could change. And I think that was something really important you pointed out in your book, and that when we talk about the future is that this concept, which I think is hard as the public, you want to know how to handle things, but I think one thing we could do better that you allude to is that it's not law. When you give advice, when we were getting early advice, it was the advice of what we knew best at that time, and that you had to be okay with switching and pivoting and adjusting to what we were learning. And I think as a practice we tried to do that. I think it was harder to get everyone to understand that that's how science works, is that we learn and we evolve. If we still practice like we practiced 200 years ago, nobody would be sitting here, right? So, but we did that in a very short amount of time, which I think is different than any other science we've learned over the decades and centuries.
So in one of the chapters in the book, Dr. Ostrom and his co-author write, while some healthcare workers died from SARS-CoV-2 and many were temporarily incapacitated, among the greatest issues was burnout. They were simply overburdened, physically, emotionally, and numerically. And the situation did not fully recover as COVID eventually waned. Indeed, it remains a problem today. I'm wondering, does that sound familiar to both of you, and is that something that we need to think about when we think about the next pandemic?
Yeah, absolutely. So as we described the scenario that was happening in the first few months, actually Minnesotans were very good at following the stay away from hospital orders. So for the first weeks or so, we were empty. We had a lot of time to be preparing and put tape on the floors and such. And then they started showing up, and I think early on in a crisis, everybody's ready to go. You know, we're Minnesotans. We are healthcare workers. We have a mission. But as time wore on, healthcare systems started pulling back some of the extra resources. There was a special hospital that was set up for COVID patients, that things were waning, that got closed down. But the variants weren't done and waves kept coming. And I can remember March 2021, we were extremely busy still. And the wave of covering for people, working short-staffed, continuing having patients coming in, and now our waiting rooms were growing and growing and growing. We had boarding patients in the emergency department. We were boarding mental health patients that didn't have anywhere else to go. I would say that first year there was a lot of resiliency, and still we're here for a mission and we're here for it, but when it keeps coming and the resources don't keep coming, and that sort of repeated pressure on people to work understaffed in less than ideal situations, that is where I think we really began to see a lot of burnout. We were losing people before March, but after that I feel like it definitely hit. So yes, it is real, and yes, it is having people leave healthcare and certainly leave frontline medicine.
Yeah, burnout is a huge issue. We definitely saw that. I can say I have colleagues that are not the same today as they were 5 years ago. They just aren't as happy. I think they were just completely fried. I show up to work every day and I love my job. I walk in and I love it. I'm happy to be there. I'm excited to see the kids, and I can remember days where I cannot see one more patient. I was just white. And we are a system of efficiency. We don't run overstaffed. You don't run with people waiting to show up and back you up when you're tired. And so I think when you get into that situation with burnout, I'm not quite sure how we solve that problem. We tried to help our staff with monetary incentives and extra bonuses just to say, hey, we recognize what you're doing, but that's not enough emotionally. And I don't have the answer of how you help with that burnout when you get to that point, because there wasn't a wing of people that could have taken over and the work needed to be done. So it's a very real issue. It's a very difficult problem to solve.
Let me just add that one of the challenges we had with this pandemic was the fact that we approached it much like a hurricane. It's going to be really tough the next 16 hours and we're going to recover. And this was one of the challenges that I also had. I was on Joe Rogan's podcast on March 10th, and I made a prediction. I said, I think we could easily see 800,000 deaths in the next 18 months, and it's likely going to go on for long beyond that. You might have thought that I was calling all of your mother some bad name, okay? People didn't want to hear that, they didn't want to believe it, they didn't want to accept it. 18 months later, we said 790,000 deaths in this country. And I think that it was that failure to understand that you're in this for the long haul. And I think, as you pointed out, Christine, the variants surely had an impact on that and changed that as time went on. Kids was a good example. In the end, in the first 3 years of the pandemic, we lost about 1,530 kids in this country, okay? In the first year, it was only 199. And I say only because people said this isn't so bad in kids. And when the new variants came out, the second and third years, we actually saw the number of deaths go up dramatically, and in kids. And again, how do you adjust to that after coming off a first year where everyone was correct in saying it wasn't as severe, but then adjusting, what does that mean for year 2 and 3? And so I think that the expectation issue is something we have to do. The next one, when the big one hits, you're going to have to say, are we ready for the next 3 to 4 years? And the two things that will make a difference there is, in fact, having effective vaccines and being able to stop it at that level, and a healthcare system that's much more resilient, which right now, this administration has stopped the research on the key vaccines that we need, and healthcare, as we know, in the next few months, we're going to continue to unfold with this new recent legislation, and it's only going to be more challenging. So neither of those are going in the right direction right now.
Mike, as you well know, there's been a lot of talk about the lack of trust in the institution of public health. You talk about it in the book. Part of that is coming from bad actors who are actively trying to discredit the agencies like the Centers for Disease Control and Prevention. Some of those bad actors are in the current administration. There are also a lot of people who honestly felt like they were getting mixed messages during the pandemic. They were wondering about why their kids couldn't go to school. You talked about, and you mentioned it earlier, you talked about that need for humility. And the need to acknowledge what you know and what you don't know when a public health crisis emerges. Is that what is needed to restore trust ultimately, and how do we get back to that trust?
Well, if I could answer that question for you, we should all here win a Nobel Prize for intellect, okay? Because I don't know what the answer is to that. It's a challenge, and I'm watching it literally crumble more every day in terms of that. Let me just give you a case in point. There's a news agency, KFF, that does routine surveys, which are really well done and well known. And just this past week and a half, they announced a new one that shows in the past 6 months, pregnant women have actually increased by almost 30% the number that no longer take a vaccine during pregnancy out of fear for what they've heard. And this is a big new change, okay? And yet we have very good data showing that COVID vaccines are highly effective in reducing serious illness, hospitalizations, and deaths in pregnant women with COVID. And we ought to be doing just the opposite. And ACOG and all the other groups are in complete agreement with that. So we're losing every day right now. The credibility is not being felt out there. But I think there are lessons to be learned about how to communicate. And one of the things I talk about in the book, because I was involved with the Biden administration, I was involved very early on in discussions about when the new mRNA vaccine data were first coming out, showing 94 to 96% protection. And there was a sense of euphoria, and there was. This was a great new advance. But having worked with coronaviruses in the past, SARS and MERS in particular, I remember very well the challenge of waning immunity, where like flu vaccines every year, they're pretty good at first. Each month they get further and further out, they are less and less effective. And I had suggested at the time, we need to find out, are we going to see ourselves 6 to 12 months from now, not with a lot of protection out there? And I had suggested what we should do is follow this cohort that gave us the initial data, and every month publish what's the percentage of protection this month. So to go from 94 to 96 to 92 to 88 to 65, with the idea that maybe you're going to need to get a booster. We could have forecasted that. We could have said, we don't know, but in fact you might need a booster. Think how people might have taken the news that following summer differently if they said, well, okay, you told us this was likely possibly going to happen, and that boosters were going to be important. We could have done that easily without it being a new set of science. It was just an understanding of how do you communicate to the public what you know and don't know. And so, again, in the future, I would recommend if the next pandemic, whatever our vaccine situation is at, convey to people what we know about it. How well are they likely to protect or not protect, and what does that mean? I tell you today, boosters are absolutely essential for COVID, particularly for high-risk individuals, for serious illness, hospitalizations, and death. Didn't mean that I think the vaccines aren't good, but it surely gives you a sense that it's not just one and out. And I don't see anything right now that's going to give us a one and out, given the technology we have now.
This is a question for our two doctors. I'll start with you, Dr. Schaefer. Did you feel that some of that distrust I talked about that was initially directed towards public health agencies, state health agencies, did you feel that was extended to providers as well? And has the pandemic changed the patient-provider relationship at all in terms of people coming into you with information they've gotten from the internet and different ideas about what their care should look like?
So I have been in practice for, out of medical school for 24 years. And I would say the first decade to decade and a half of practice that my job was pretty straightforward. Every once in a while you get someone who would come in and say they didn't want to do vaccines, or they had questions, or they weren't sure. But nothing that kept me up at night. And I would say over the last 6 years, things have changed dramatically. I think when COVID came out, when the COVID vaccine came out and I could get mine, I almost cried. Like I was almost in tears because it was just, I was so happy that there was something that I could do. But all of a sudden there was a cohort of people coming in that really were like this is gonna mess up my body, this is gonna do all these things, just kind of this new twist on things. And I would say that that has just continued to worsen over the last 5 years, or 4 years. And the last 8 to 12 weeks have been horrific for vaccinations and what we're trying to do to promote childhood wellness and health. I kind of have different cohorts. And I will start by saying I think every parent is trying to do the best thing for their child. No parent is coming into my office wanting to hurt their kid. They want to do what's best for their child. And there's just, the internet is fantastic because you can have all this information, and the internet is horrible because you can have all this information. So, I have parents coming in that are crying because they're afraid that there won't be vaccines in 6 more months, and can I give my kid all these vaccines early so that I can protect them now? I have parents coming in that are just confused, that are hearing lots of different things, and if we can talk through things logically, they feel a lot better. And then I have a cohort that comes in that wants no discussion with me. I'm not quite sure why they want to come see me anymore, because they obviously don't trust what I'm saying about those things anymore. And it's really hard. There's a lot of belief in a system that doesn't really have any backing, but it's become law to them. And I would say that just has been exacerbated over the last 5 years.
Dr. Quinn?
Yeah, I think my relationship with my patients is different than yours, in that I'm meeting them and I haven't had a relationship with them before. Definitely a lot of distrust in the system, I think. I think when we first started having patients come in who weren't vaccinating their children, I did feel some sort of anger about it, and not understanding, I guess a little bit of anger about it. And I've had to realize in the last decade that I can't feel that way. It is always a parent who is making a decision, whether I think it's a good decision or not, because they feel it's important for their child. But having a lot of discussions with someone I don't know and they don't know me, I've generally tried to lean towards the humility part of things. I don't know how that plays these days, to be honest with you. Right now, people seem to want someone who just comes out and says, this is the way it is, whether there's any backing behind it or not. So I don't know how the humility plays. It still is the place I start my conversations from, but I don't know how that plays anymore. I'm not sure.
I'll have a few more questions here for Dr. Ostrom, but does anyone in the audience have a question that they'd like to ask?
I was wondering, you said you're starting to see it was easy before, and now in the last few years has it changed, but parents are resisting. I wonder, is it the same parents, that they were okay until a certain time, and then they suddenly now are not okay?
Right, so I take care of families for a couple decades, so I know them pretty well. And I've had families that I've just been shocked. They are parents. We talk about this in our practice. One of my partners is here with me, but that there's this cohort of kids where they have 3 kids, and the 8-year-old is completely vaccinated, and then the 5 or 6-year-old is partially vaccinated, and now the 2 or 3-year-old has had no vaccines. And there are several families in our practice that is the trend we've seen, and it has nothing to do with what we have told them as providers. I would say it is completely coming through social media, politics, and it's so hard to have a discussion with some people. Some people just need some different information, but when I try to understand, right, come from a place of humility, why are you where are you coming from, what are your thoughts? I just feel this way. And I don't know how to make you feel better when you just feel that way. And I was telling Dr. Oswald, I was at the American Academy of Pediatrics National Conference a couple weeks ago, and Dr. Paul Offit, who is a vaccine guru in our country, was speaking. And he brought up that, unfortunately, we probably will get to a place where we have to have really bad things happen before people want to believe in vaccines again. And I think the generation that I'm taking care of right now has the privilege of not having you know, my grandma's sister died when their house was under quarantine from diphtheria, or their best friend from school losing the use of their leg from polio, or, you know, multiple deaths from measles. So I wish I could say that's not where it has to go in order for us to understand again, but it really feels like running into a wall right now.
Yeah, let me just make a comment on that, because I think you really hit on an important point. We forget, or we never learned what the past was like. When I was born, the year I was born, we had 68,000 cases of polio in this country, including over 21,000 paralytic polio cases. I was alive for that. In my first grade, the boy who sat just next to me died of measles in our first grade year. I think people can't really fathom going back to seeing 66,000 cases of polio in this country. But that's exactly what will happen with each cohort that vaccinates fewer and fewer people. We're going to have more and more, as we would say, susceptible people. But one of the things that we're trying to understand, and our center is working on this, to try to understand how do we get here and what are the different types of patients, because we find out that it's not a single issue, it's not a single patient. It's different. But what really was illustrating this point is we're now hearing from our veterinary colleagues that we have more and more individuals that refuse to vaccinate their dogs and cats for rabies, diseases like this, because they have the same message they're giving you, the same feel. I just don't feel it's safe to give my dog, I love my dog, and to give him a rabies vaccine. Well, if you've ever seen a domestic animal with rabies, you know you want to avoid it. And so I think that's just an example of, it's bigger than the human medicine, human interface issue. It's all about all these issues. And I'm very afraid that we're going to be at a point where it's going to take some huge crises to actually break through that. But having said that, one of the most, let's say, memorable statements I've seen in the past year was from a father of one of the young children that died in the Texas measles outbreak. And when he was asked about why they weren't vaccinated, he explained that, why not? And he said, her death was God's will. And so therefore, that is what, in fact, why he was still not vaccinating his kids. It's up to God's will. That's very hard as a clinician. How do you respond to that?
Like, I think a lot of people in this room and around the world would rather not think about the COVID-19 pandemic, much less revisit some of the darkest days of the pandemic and envision a future pandemic involving an even deadlier virus. But as a leading public health figure in this country and a longtime advocate for pandemic preparedness, did you feel like you had a responsibility to write this book?
This may sound counterintuitive to you, but this book is a love story, a true love story. I have the wonderful gift and the horrible reminder every moment of my career where I'm sitting behind my desk because I have a large electronic picture frame that my kids gave me. And every 30 seconds, a new shot or shots of my grandkids go wheeling by. And I thought to myself, my God, if I can't do more to help this world be better prepared for my kids and grandkids, who am I? What am I? And so, in fact, it's of note, again, I've served a role in every presidential administration since Ronald Reagan, including the Trump one. I was a science envoy for the State Department, etc. So I've always been apolitical. I was at the State Health Department for 25 years, served 2 Republican governors, 2 Democratic governors, 1 independent wrestler. And, can tell you that, again, I'm not partisan. But I saw what was coming, and as Chris can tell you, the night of the election, when I saw what was happening, I pulled out the old 2025 document, this document that supposedly they weren't following, but in fact would be. And we knew that Mr. Kennedy was likely to be nominated as Secretary of Health and Human Services. And I said the next morning, I sent out a note saying, I'm in for 4 more years, I can't leave now. And it's because if you have a love story, you can't just walk away from it because it's tough. And I think that to me is why I'm here. And I think a lot of my colleagues are very much in the same boat. You care, and we have to have a little better prepared for our kids and grandkids.
Well, unless there are any other questions, I think we're going to wrap up here. You'll be able to talk with Dr. Ostrom downstairs. He's going to be signing copies of his book. But I'd like to thank you, Dr. Osterholm, Dr. Kleddy, and Dr. Schaefer for taking part in this conversation. Thank you to the Minnesota STEM Book Festival, and thanks to our audience for being here and listening to this wonderful talk. And as I said, Dr. Osterholm will be downstairs signing copies of his book if you'd like to chat a little bit more. Thank you, everyone.